Today, we're going to be talking about treating with sound, and we're going to be discussing MR-guided focused ultrasound. And so I'm excited because you're going to hear actually from two different people. We are going to have a presentation first by Dr. Tim Meakem. He is the Managing Director and Co-Director of the Research and Education team at the Focused Ultrasound Foundation. He oversees the growing number of research projects that the foundation is supporting, leading to academic research institutions around the world. He is has been the CEO of a research organization, the CMO of a medical device company. He has also held positions of leadership in anesthesia, including a private practice and teaching at the University of Virginia. So we're excited to have Dr. Meakem with us. And then we also have Bobby Krause, and you're going to be hearing from him. Bobby is a person with Parkinson's who's actually experienced this treatment. He was a college athlete turned to sales executive. He's a father of two boys. He was diagnosed with young onset Parkinson's at the age of 42 back in 2016. He's the president and founder of Be Still Foundation, which is an organization created to help cover the cost, raise awareness, and provide educations on the benefits of focused ultrasound for those in need of tremor relief. So you're going to hear the scientific perspective and you're going to hear the personal story perspective. And I encourage you all to drop your comments and your questions in the chat. We're going to do questions at the end, and these can be questions for both of our speakers today. So I'm going to hand this over to Dr. Meakem, let him kick us off with the scientific research explanation of what's going on with focused ultrasound and the indications, and then we'll hear from Bobby.
Well, thanks, Anissa, and I'm going to share my screen, and I'm going to make a copy of these slides available to the group afterwards, so don't worry about having to take notes because you can get access to this afterwards. So I appreciate the opportunity to speak to you all today, and I thank you for the PMD Alliance for co-hosting this with us. And the agenda for what I'm going to talk about really is just a brief introduction to focused ultrasound, just to make sure that we all understand what we're talking about, and even briefer introduction to the foundation, just to know who we are and who we aren't, and what our purposes are. Most of the time is going to be spent on the research update, and then plenty of time left for Bobby Krause to give his talk afterwards. And now, MRI 40 years ago was something that we all are familiar with, but it really took a long time for it to become available. And now almost everybody's either had an MRI or knows somebody who's had an MRI, but it took basically 40 years for it to become prevalent. And focused ultrasound on the therapeutic side is kind of the same type of thing. It's still unknown by many. It's dubbed medicine's best kept secret, but has the potential to really revolutionize therapy. And the idea is just like a magnifying glass heating a leaf. You have multiple transducers aiming at a target, and you can position the target wherever you want. In this case, there's a patient with breast cancer, multiple transducers aimed at that target, and the individual beams of focused ultrasound pass through the body without any harm until they get to the point of convergence. And at that point, it heats up and thermally ablate or otherwise burns the tissue to treat the problem. And here's a left-handed architect who was treated for essential tremor, but the target for essential tremor is exactly the same target that they use for tremor-dominant Parkinson's disease. And see, he has real trouble picking up a jelly bean and moving it from one spot to the other. And here are his concentric circles, and here is the target, which we're trying to aim at. I hope you can see that well, but the blue dot there, and that's where we're going to try to have his tremor treated. And remember, this is done awake with no anesthesia, no incisions, no burr holes, nothing penetrating the skin. And right by the red arrow here, there's the target where they actually made the lesion. And here is his concentric circuits afterwards, which was dramatically improved. And here is a picture of him now moving the jelly beans from one to the other without any problem. And that really is what we're talking about here. I do want to say one thing is that how you use focused ultrasound is highly variable depending on what you're trying to accomplish. And we're just really talking about a portion of that, really the thermal ablation part, and a little bit we're going to talk about blood-brain barrier opening. But there are many other ways that it's being used. And if you looked at this 15 years ago, there were three areas where we were medical indications where we were going after with focused ultrasound, and now there's over 180. So it's really a big process with this, and we're going to talk about just a portion of it. And there are many different devices you can use, but this one here is the Insight Tech device, which is one that's approved in the US and is predominantly the one that we're going to discuss going forward. A little bit about the foundation. This is really a credit to my boss, Neil Cassell, because he was involved in the development of some other things before, something called the gamma knife. And he saw how long it took for that to go from invention to actually being widely available to treat patients. And when Focused Ultrasound came out, he said, I can't let this happen again. And he looked around and he tried to find a mechanism that would help with this, but he couldn't find it. So he felt obligated to invent. And that's when he started the Focused Ultrasound Foundation. And we're really a unique medical research, education, and advocacy organization. We're tax exempt. And our total goal is really to accelerate the development and adoption of focused ultrasound, make it a global standard of care, and then we're going to pack the bags and go home. That's it. That's our purpose. We also recognize that we can't do this alone. So we partner with a lot of other organizations to try to help move this along as rapidly as we can. And our funding is it's all donations, and we have about a $15 million a year funding. Greater than 60% goes to the research. If you want to fund, there's our link. And this is the main purpose, the main thing that keeps me going to work every day and makes us go forward. If you look at the gray line going up here, that's how long focused ultrasound would take if there was no foundation. It takes a long time to get from here to here. But we think if we can move this line to the left to the green line and accelerate the process, every one of these lives in the yellow area is a life that we're improving by this care. And that's what we're all about. So now I'm going to talk a little bit about the research status. This is the main study that was for essential tremor. It's FDA approved. The target is the VIM nucleus, and this is the technique that's used right now. And on this study, they had about 75 patients. They had good p-values, great control to improve the tremor care, and it was preserved. It lasted for 12 months, and the quality of life and disability measurements were all significantly better. But there were some problems. There was a lot of people had gait disturbance, particularly in the beginning. 36% at 3 months. Now, over time, it improved, but still almost 10% at 12 months. And the same thing with paresthesias or numbness. So 38% and at 3 months went down to 14%. Now we're going to talk a little bit more about that in a minute, but that's something that is a bit concerning, and people have been doing things to make that better. This is Medicare approved for all 50 states. It was initially FDA approved to treat one side of the brain, and then they did some studies and now they approved a staged bilateral treatment. And what I mean by that is I can have one side done today, and then I can come back in 9 months and have the other side done. And the reason they do that is because it really out of an abundance of caution, because when they did this by open surgery, they obviously didn't want to go into my brain twice, so they did things on both sides, but they found the complication rates really went up. And so they said, we're going to have these separated initially here because we just don't want to have problems related to swelling or something that come by after that. The other approval for this is for tremor-dominant Parkinson's disease, and this target is the same, the ventral immediate nucleus. And the study is pretty similar. They had 27 patients, had 62% improvement, and they had not very many side effects. They had some paresthesias, some numbness, and some tingling, but also one patient had ataxia. Now, this has got Medicare reimbursement in some states, and basically 38 of the states here. But what we found is that if you're in a state like Texas that doesn't have this approved and you want to go to, say, Virginia, where it is approved, you can do that, and typically Medicare will pay for that. Now, we always say, confirm this with the treatment site, make sure everybody knows what you're doing, but our understanding is that is okay. So you may have to do some traveling, but you can get your Parkinson's disease tremor as well. Now, sorry, this is a very busy slide, but the points I want to make on this are really two. One is over here on this left-hand side. You can see kind of the goal line is the incidence of DBS treatment, and the blue line is the change in MR-guided FUS. So you can see that the DBS is pretty stable, but the MR-guided FUS is really increased. And the other thing that's important is this part right here, which is so busy you can't see it. So I tried to magnify it. This is a poster session, which is the only version I have of this. So sorry for the size delay. But this talks about the side effects. And remember, I talked about, the pivotal study for these had, some significant side effects, some, 3 or 4% up to 25%. And as you looked at how, and the neurosurgeons don't like this either. They don't want to have the side effects either. So they've been working hard trying to say, how can we define our target to get what we want and not get what we don't want? And they've done a pretty good job. And this is 2017 to 21, over 6,000 patients. And you can see the side effects have dropped dramatically. There's nothing in the single digits, and a lot of these things are 0.1 or 0.2, which is a tremendous improvement from that. But even if you go to 2022, which is the last year for this study, some of these are down to the 0.03 and 0.05. So really, they're getting this smaller. And when we talk to the neurosurgeons that do this, they say their trend is that they are making a smaller lesion size in the patient to try to get what they want and not get what they don't want. And that's really important. So now we move on to the other FDA approval, which is for dyskinesia. And dyskinesia is kind of a family of things. It involves motor fluctuations, rigidity, bradykinesia, involuntary motions of your extremities. All of these things are kind of lumped together. And the target for this is in a different spot than we had for the tremor. It's in the internal portion of the globus pallidus. And this study is a large study. They had a good response, almost 70 patients, and they really didn't have too many pallidotomy, which is this treatment is the pallidus, so they call it a pallidotomy related side effects. They have a person with dysarthria and some visual disturbances and some facial weaknesses. Medicare coverage is not covering this yet, although it's been approved for over a year. That process takes time, but it's something we're watching for, and certainly we'll announce it in our newsletter if and when it happens. It's interesting that typically Medicare covers something first, and then the commercial insurance covers it. But in this case, the Anthem Blue Cross and Shield is covering it in a number of states already. One of the things I want to tell you about dyskinesia is kind of a family of areas to treat, and one of the challenges with Parkinson's disease is you really have to look at where they're having their symptoms to decide where you're going to treat, because there aren't just these two spots to treat. So I've got a little bit of an anatomy lesson for you here. Here's the globus pallidus over here. These fibers run down, around, and up. The subthalamic nucleus is a place that's predominantly done in Europe, but that's another target for this. The pallidothalamic tract, or the PTT, is right up in here, and the zona incerta is another place that they're looking. And part of the reason for this is they're looking to see what's the best site to get the symptom relief that we want without getting the side effects we want. And part of the variable for that is it's different for different patients depending on what their symptoms are. So in the palatal-thalamic tract, this is a study that was done in Switzerland, and it was a mixed patient. So some were tremor dominant, some had rigidity, but there were a lot of patients were mixed. But they had a good response, 55%, good low p-value. They did have some side effects. Now, this is a 50-patient study, so it's not quite as big as the other ones, but they had some speech difficulties and some problems in soft speaking. And this also prompted a large study in the U.S. Where they did 50 patients. And the important thing about this is the first time they allowed for the potential of doing bilateral treatment. All the Parkinson studies beforehand have all been unilateral treatment. So the patients can have a staged bilateral. I could have my treatment today, and then after 6 months, I could come back and have the other side treatment. This one has not been published yet, and there's no FDA action yet, but we're hoping, and hoping is always a question mark when we're looking at the FDA, but we're hoping that we're going to see it published and get some FDA action in the first half of this year. A couple of things to note. One is that the symptoms did not completely resolve, and part of that is on purpose, because the physicians, in talking to their patients, they want to get the best possible results without the side effects, and trying to have a smaller lesion that they make might help them accomplish that. And we think we're seeing that in the release based on that poster. The other thing is what happens with the ongoing progression of the disease. Because, essential tremor and Parkinson's, they progress and get worse over time. And so one of the things that we're concerned about is you might get someone feeling better and have a good treatment today, and then in a couple of years, their disease gets worse and worse, and then all of a sudden their tremor starts to recur. Now, this has been going on maybe 5 years or so, and we haven't really seen that happen yet. We haven't seen reports in the publications about this or anything, but we're watching for it because we're concerned that this may happen. One good thing about this is if it does happen, you can go back and retreat with focused ultrasound. It's not like radiation where you can have a max and you can't have any more. So there is a plan to handle it if it does happen, but we have not seen it as of yet. So in the next steps for movement disorders, we still have some questions like, is the same technique needed for both sides? Maybe better do one technique on one side and something different on the other side, and what staging is really needed, if at all. The other one is what size lesion is optimal. As we talked about, if we can decrease the size to a certain point, that is good, but we also don't want to decrease it too small because that'll risk our effectiveness, but it'll also give us less side effects. So working out the best size lesion is still something that's under discussion. And part of that comes down to what is the optimal targeting technique. The way most of these are done is they use the traditional coordinates where they have bones on your body and they have so many millimeters over, and this is where the target is on a map for everybody. But my brain might not be the same size as everybody's brain, so it's better if we can make it more personalized. And with MRI tractography, they're actually looking at my brain, and they can tell where the lesions are and do an anatomic map of my brain and generate a location with that. It might be slightly different from the generalized map. And so most places are actually doing both right now because there's errors in both, but they want to look at both of them and then they're picking the spot they're hitting, they want to go after. But that is still something that is improving over time, and we think it will continue to improve. So everything up till now, we've really talked about the symptoms that you get for either essential tremor or Parkinson's disease from the movement disorders. But one other thing I just want to mention, there is a group that's trying to say, let's see if we can get to the underlying cause of Parkinson's disease. And it's really, they're looking at using the technique for opening of the blood-brain barrier, which kind of protects the brain from things in the circulation, but it makes it harder to get things in and get things out of the brain. And they're trying to see if they can use therapeutic agents to actually treat the cause of Parkinson's disease and make it go away. And we're not going to spend much time on that, but I wanted to let you know that we're not just about treating the symptoms. We're also looking for other things that we can really get to the root of the problem, and that is wonderful. So, which is best for you? If you're looking at this, it's not really a question of what's right or wrong, but more of a decision for you to make. And the biggest differentiators I've heard and seen is that if you do DBS, it's an invasive procedure. They make incisions, they take burr holes, they put electrodes through normal brain to get to the target they want. And a lot of patients say, I don't want that, I want something else. And focused ultrasound doesn't have any of those incisions or things as a part of it. So that part is all good. But you also have to look at the other piece, which is for people who are really conservative, who say, I want to try this. And then if it doesn't work, I want to go back to right where I am now and I haven't lost anything. Well, if that's your situation, you probably want to have DBS because you can pay to have all those things removed. And if they didn't have any bleeding or hemorrhage or anything when they were inserting it, then you should go back to the way you are. Whereas with focused ultrasound, there's no undoing it. You're thermally ablating the target, and the side effects have gotten a lot less. And in that poster, some of those things are down to 0.01%. But if you're that one, you got to live with it, whatever side effects you had, and they typically don't go away. The other interesting thing about this is that for DBS, you can do both sides at once, whereas with focused ultrasound, you have to do these staged, separated treatments. But the good part for focused ultrasound is you really don't have multiple MD visits or surgeries intervention. Once you're treated, you're done. Whereas for DBS, a lot of times the neurologist has to come in and tweak the output and adjust things, and then they have to occasionally replace the leads, or certainly they'll have to replace the battery pack. So those are kind of the decision-making processes of it. So what to do if you're interested in focused ultrasound treatment? Basically, it's okay to learn what is available for you, even if you decide it's not for you. And if your movement disorder is predominantly tremor, then I'd go to this link and find a convenient treatment provider and contact them and say you'd like to get treated. If you're dealing with tremor for Parkinson's disease, you probably want to find a place that's covered in the States if you're covered by Medicare. And if not, you're going to need to probably travel to theirs so you don't have to pay the cost. If you have motor fluctuations or dyskinesia, those types of things, you probably are going to, if you have the capacity to cash pay, you can do that. But the cash payment is around $40,000 or so. So it's not like it's a small chunk of change. For most people, you have to subscribe to our newsletter. We're watching for this. And then when Medicare starts to cover this, we'll let you know when and where. So there's a lot happening. So the newsletter is a good idea for this. One other thing, we had a patient who is an artistic guy, and he wanted to make a movie about his tremor being treated, and he made a film about it, and it's worth the time to watch. And here's a link, and you can get this afterwards if you don't have time to write it down. And now I'd like to stop really, and then we're going to go ahead and let Bobby talk to y'all.
So again, my name is Bobby Krause. This is a little bit of a way of introduction. I'm a little northwest of the city of Philadelphia in Pennsylvania, in the heart of Amish country. And I tell you that because it's a beautiful place to live, but it's also where I believe that my young onset Parkinson's kind of originated from, either living on, or working on farms my entire life. I think from what we're learning now on insecticides and pesticides and herbicides, they can be a significant contributor to Parkinson's disease. So wanted to thank you for the time to be able to share with you a little bit about my journey. And again, a couple of housekeeping items, just as you kind of listen to the speech that I give. And again, we're going to try to shorten this a little bit so that we have plenty of time for some Q&A. But first of all, want to thank you all for being active in this process. I just read a book called "I Will Cure My Parkinson's," And she talks about her own personal journey and taking a very active role in trying to educate herself and gain knowledge and understand what is her best course of treatment plan versus just a passive recipient of medication or information from a doctor. So again, the fact that you're on the call, you're trying to learn more and understand more about what options may be available. So kudos to you for that. For those that have caregivers on the phone, thank you very, very much for being here. I always tell everybody when I married my wife 25 plus years ago, and we said for better or worse, I'm sure she didn't envision at the age of 40 her husband being diagnosed with young onset Parkinson's and some of the side effects that she was going to have to deal with going forward. So for those that deal with us and help us out, big thank you. For those that my wife for years helped brush teeth, but do my buttons, whatever it may be. Again, it's a huge thank you for all that you do for us day in and day out. As Dr. Meakem said, this is a very personal decision. So again, I'm not steering anybody in one direction or the other, but just want to simply share you my journey and how my thought process went to going the focused ultrasound route versus DBS at this stage of my life. And again, I think just to kind of reiterate, and there's another young lady on the call here that explained this to me very well, is this isn't a panacea for Parkinson's, but it is something that helps provide a significant improvement in quality of life for those that are really struggling with tremors. And in my case, I was tremor dominant, young onset Parkinson's disease with uh, tremors being by far the worst symptom I had, as well as some dystonia and then some bradykinesia, kind of slowness of gait. So we'll talk about some of the impact that FUS had on that procedure for me. Then I think lastly, I think it's really important to recognize that both in the essential tremor and the Parkinson's community, we're a very tight-knit group. So always remember, we are better when we're together. So take advantage of the community, take advantage of all those that are willing to share their stories, their struggles, their wins, their losses, but we're all here together to work through this together. Nobody really understands what we go through like we do. So again, I always find tremendous solace and great respect for those who are willing to share their story and be vulnerable at times and really, again, share from their heart what they're going through, what they're experiencing, and how we can help each other. So that's kind of the housekeeping items. We'll kind of jump into my story. On the right-hand side in the link as well, at different times, Kelly's going to provide links to some videos where you can see some before and after results, as well as an incredible story of a young mother who was battling essential tremors for 18 years. And you can see her results from Focused Ultrasound and how it greatly impacted her raising of her young children. So some incredible stories there of some successes with this procedure. But as Anissa mentioned earlier, I was a college athlete, turned husband, turned executive, held multiple VP roles in the corporate world, and then ultimately then turned a father of two, which was, for me, of all those things I listed, being a husband and a father were the things I believe I was put on this earth to do. So I was heading in the plan that I wanted to. Everything was going fine. Everything was going as I had kind of laid out in my journal, until I started getting a nervous tech at around the age of 40. Again, being 40, being a college athlete, helping to start a fitness equipment company, the last thing I thought that this nervous tick was going to be was a young onset Parkinson's diagnosis. So at the age of 42, I received my formal diagnosis. And I think like many of you probably can relate to me, I found that the medication was often worse than the Parkinson's disease itself. So I really struggled with medication, everything from significant bouts of depression, night terrors, cramping. I'm very much the extrovert. I became very much the introvert. So in bed by 6:30 at night, isolating myself from my family and friends was kind of the what you saw at the Krause house, for about a 3 to 4 year window as I finally decided to get off the medication. So what was kind of the defining moment or catalyst for me was I came around the corner at my son's 12th birthday party. And we had a big party in the backyard, and I came around the corner and he was talking to some of his friends and he was apologizing to his friends about the way his dad was acting. His dad had Parkinson's and his dad was on some medication that made him a different person. Immediately ran in the house, took all my medication, flushed it down the toilet, called my neurologist and said, "Hey, we need to look at a different course of action." She said, "Let's slowly wean off." I said, "No, I don't think you understand. We're going a completely different direction." So I had the privilege and honor of meeting with a movement disorder specialist who is very keen on staying current with the latest and greatest technology and innovation. And she finally gave me some hope in 2018 about focused ultrasound and the potential that it could do to help reduce some of the medication that I had for the tremors, but also really restore quality of life for me by removing the tremors altogether. Uh, so so if you can find a movement disorder specialist, I strongly recommend. The challenge with them is there can be a significant waiting list for first-time visits. I've heard as much as 18 months recently as people are finally getting an opportunity to visit. They have short windows, but well worth the investment in finding a movement disorder specialist if you're able to, in addition to your neurologist. I found great benefit of that. So 2018, found out about the Focus Ultrasound, super excited to get on the waiting list. And then, of course, COVID hits and kind of slows everything down from the FDA approval process to just the treatment process and just slowing everything down. But on June 9th of 2022, my life was truly changed forever. Uh, it was a day that had a mixed bag of emotions, everything from just excitement of would my tremors actually be gone, and then obviously the angst and the nervousness. I'm looking at some of the text messages on the side here. We're talking about ablation of the brain. I mean, those are some scary terms when you're thinking about the brain and the permanency thereof of having that ablation and quote unquote rewiring the brain. So went into this with a lot of angst, but a lot of hope that I would see that mitigation and that reduction of tremors, so I could get back to kind of a pre-Parkinson's normalcy and an improvement in quality of life. When talking about the procedure itself, a lot of people always ask me, what was it like being in the tube? What was it like leading up to it? So I'm going to kind of walk you through it. And again, any questions that you have, feel free to hold on to them to the end or shoot them in the side, and we'll try to answer them as we can. But partly the reason why I went the focused ultrasound route was one of the things that, in addition to what Dr. Meakem shared, is that if you do have focused ultrasound down the road, again, I could use focused ultrasound to kind of improve upon some things, but also it doesn't disclose me from having DBS down the road. So in 15, 20 years from now, if other dyskinesias and other symptoms manifest themselves, I could have DBS as well. So for me, at the time, at the age of 48 years young, I decided I wanted to go with a kind of an in and out procedure, something that was incisionless. Didn't want the risk of infection in the brain or in the chest area as they implant the hardware, both in the brain as well as down in the chest area for the, a pseudo pacemaker, we'll say. So that was really the direction that I wanted to go, and was very fortunate to have a neurosurgeon at Penn that had performed many of these procedures. In fact, I believe on tomorrow he'll be performing his 600th focus ultrasound at University of Penn. So I was quite confident in the hands that were going to be performing the MR to guide the proper location on the thalamus to do my procedure. So once myself and my wife and my children went through the decision-making process, like I said, on the morning of June 9th, I went down to the facility at Penn, started with some prep at 10 a.m. So they do have to shave your head for this procedure to ensure that the ultrasound waves can properly get to the area of in the area that they need to target. So had the haircut, got a couple other things done, get ready for the procedure. Roughly 12 o'clock, they took me into the MRI room. There is lots of interactions. I think I had 5 different staff members there, constantly talking in your ear, sharing with you what you're going to experience, what's going to happen. Put a warming blanket on, feet under or pillows under your legs, made you as comfortable as possible. So what's a little different with this procedure and this MRI experience, in addition to laying flat on the table and having that typical device that kind of locks the head and neck area still. There's a device that goes around the skull that it's kind of a cooling device that attaches to a kind of a skull cradle. But they use certain screws where it just kind of pinches up against the head. So again, there's no incisions whatsoever. But it's just a device that again just cools the brain as the ultrasound waves come at different opportunities to heat up that area that needs to be ablated. So typically what happens when you're there is I've heard as few as 3, as many as 7 times where you go in and out of the MRI tube. And typically they're in 10 to 15 minute increments. So like for me, I had 5 different times I went in and out of the tube. The first time was for the doctor and the medical team to really pinpoint that spot on the brain with via MR that they were going to focus on ablating for that day. The second time, because of the dystonia that I had in my foot, my toes were completely wrapped underneath the bottom of my foot, so I actually walked on my toes. During the second, they call it sonication, or patients that go through it called a zap. It's kind of when you can kind of feel a warming of the brain area as they're heating up that ultrasound waves and it's targeting that area. I looked down at my toes and my toes just completely unfurled. And it was the first time in months, maybe even years, that I could actually see my toenails because my toes weren't curled underneath my foot from such bad dystonia on that side of the body. The third time they brought me in and out of the tube. And again, one thing I forgot to mention is you are awake during the entire procedure, which is just a experience within itself. I always say that next to marriage, next to having 2 sons, and next to my faith experience, being in that tube and seeing these things happen in real time is just the most incredible event that I can ever attest to. But on the third time that I came in and out of the tube, I had such bad muscle rigidity that when I went in that morning, I was roughly 6'5". When I left the facility that day, I was 6'6". Not that I actually grew, but my muscles relaxed. And my son, who I left it in the morning, that we always kind of have a competition as to who was taller. He was taller that morning. When I got home that night, he could quickly notice that I was taller again. So that was kind of our little laughing point of the day. But on the third in and out of the tube, it was such an amazing experience where I'm 6'6", roughly 320 pounds. So fitting into an MRI tube itself isn't the funnest of endeavors. So if you are a little skittish on claustrophobia or space, they can help you with that just to keep you calm. But as they pulled me in, you could actually hear my arms squeak against the side walls of the MRI tube. That's how much, how little space there was for me. But on the third one, I could just feel my body completely conform to the circularity of the MRI tube. I mean, it was just an amazing experience. And I just sat there and I started to cry because I'm thinking about, okay, if I'm seeing this type of results with my toes and this muscle rigidity and just the overall tightness of the body, I can't imagine what's going to happen shortly when they start addressing and really impacting the tremors that I'm seeing primarily in my left arm. So on the fourth insertion back into the MRI tube, I could hear the doctor talk in my ear. He said, we're going to be in here for 15 more minutes, but this one you should see some reprieve of tremors. So when you're in the tube, you have your arms crossed over your chest, and I could hear a countdown, and you can kind of feel the warming sensation start at the ears and work the way to the top. And I looked down at my arms, and my arm became completely still. So if you watch some of the videos that are on the screen, you'll notice that I had a very debilitating tremor, and to be able to in real time watch that tremor, feel that tremor just completely dissipate, and feel your body go still after a roughly a 10-year battle with tremors was just one of the most overwhelming experiences of my life, and really is what has led me to the course and the journey that I'm heading on to now. We'll talk about that a little bit more later, but once they've identified and pulled me out, and again, we do kind of the concentric circles, finger taps, obviously holding a glass of water, a variety of testing that the physicians and the medical team perform while you're in the tube. They put you in one more time just to make sure that they have the ablation exactly to the size that they want, the lesion that they want, and then one final check. And then I was up in the recovery room by 2 o'clock, and actually was discharged and sent home at 5 p.m. that night. And I probably shouldn't have done this, but at 11 o'clock that night, I was so excited. I took my sons out on a trail hike, which I hadn't done in, I don't know how many years it's been, where I've been an active dad with my sons again. And just an amazing opportunity to share with them the results of the day. So that's obviously the great side of things, the good side of things. You know, were there some challenges to the process? Yes. And it's very similar to what everybody else experiences. There's about a 2 to 3 week window post-procedure where I had some spatial recognition issues. I would cut corners a little too tight from the left side, being um, just again debilitated with tremors. I would cut corners a little too tight and constantly hitting the door jambs, but that subsided in about a 2 week window. And then stop signs and just other uh, again it's kind of that spatial depth, et cetera. It took me about a 2 week window for that to overcome. And then I had a little bit of an imbalance issue, which again is a known component of some gait challenges. Is again kind of the pre and the post procedure, but that was all remedied with physical therapy and just the healing of the from the procedure. So with all that said, again for me it was such a life-changing experience that I had the privilege and honor of leaving the corporate world in May of 2024, and I started the Be Still Foundation. The Be Still Foundation is really driven to do three things: create awareness, like Dr. Meakem was talking about, and trying to be able to reach and improve the lives of many people well in advance of what it would do on its own natural state of movement. Two is to provide an advocacy network. So if anybody else has any other questions, we have a network of people throughout the country, men, women, essential tremors, Parkinson's disease, as young as 40 years old as 85 years old, that are all willing to share their story. Again, both the pros and the cons. And as mentioned earlier, you know, we do have an incredible community that's willing to raise their hand and say, hey, this was my experience. And again, I think that's where we can find a lot of value and strength in the numbers that we have. And then thirdly, we provide the financial resources. So Dr. Meakem shared a lot of Medicare coverage for the various procedures. Obviously, I'm not at Medicare age yet, so mine was an out-of-the-pocket procedure. I was so blessed and fortunate to have an employer who was willing to make an investment in our family and paid for the procedure. So for me, it's become my mission and goal to provide financial support for those who want the focus ultrasound that aren't able to either have to cover a copay or a full cash pay. We've helped provide wigs as well for women who were concerned about shaving of the head. We provided wigs, transportation, whatever we can do to help out and remove any obstacles or hurdles for anybody wanting the procedure. That's what the foundation is for. So it's been a great honor and privilege. We're currently working with 9 patients from as far as Australia, North Carolina, Texas, New Jersey, PA, North and South Carolina. So it was a tremendous experience for me, and always willing to share my story. I'm just looking at a couple questions on the side there. For David, yes, it was the left side only. I had tremor dominant Parkinson's that was only on the left-hand side of the body, so that was all that they simply targeted. And from what I've been told, and Dr. Meakem, you can confirm with this, but for patients with Parkinson's and tremor dominant Parkinson's, when it's identified and isolated to one side of the body, that's kind of the ideal candidate for the procedure, and why I think I saw the incredible benefits that I've seen and the success I've seen from my procedure.
Yeah, I think that's right. The part of the challenge is that it's only FDA approved to do one side right now. And so if somebody has really bad disease on both sides of their body, then it makes it hard to say, well, we're going to fix one side and you got to hang with the other side, at least under the current FDA rulings.
Excellent, excellent. So with that, I think we have 15 minutes left. I think the most valuable use of the time is to hear from you. You know, what questions you have. I know there's a lot of interest in this topic. We're seeing it at the foundation where daily we're getting calls, emails, texts. You know, can you help a friend with essential tremor? Can you help a friend with Parkinson's? So, Anissa, we'll turn it back over to you, and we'll be here to answer as many questions as we can.
Awesome. So several questions that I think will be directed to you, Dr. Meakem, and you answered it as it came in earlier, but then I think there's a follow-up to it. So originally it was, is this a one and done procedure? And I think you said that there is a possibility that you might need to go back and you can have it done again later. So the question is, have you seen many people having to come back for a redo?
Yeah, it typically is a one treatment and then you're done. But we have not seen any published case reports of this patient had it, they had it treated well for 4 years, then it got worse and worse, and we treated again. Now we believe that we may see those at some point, but and we're watching for that, but we haven't seen it yet.
Okay. Awesome. And then we had a question, how was the ablation target identified? Example, how is it known that the correct cells are being destroyed?
Well, the anatomic basis is this ventral intermediate nucleus of your thalamus, but it's not visible. If you put on an MRI and say, point to my VIM, you can't do it. You have to know where it is related to some bony structures, and it's a couple of millimeters over, and you got to remember it's three-dimension, right? So you got to get the X, Y, and Z to have it accurately identified. And remember, the way it's identified is really there's two ways. One is the map for everybody's brain, and not everybody's brain is exactly the same size, et cetera. So it's about there, and the targeting, it has some errors in it, so it's about there. But that's why in the beginning they do these test sonications to make sure that they're getting what they want, but more importantly, that they're not getting what they don't want. Because those test sonications, if you say, my fingers got tingly or something, then they say, okay, we're going to move away from that, and that those test sonications are very low power, so those will go back to normal.
This person said, I've been following this for years. How is this better than a thalamotomy?
Well, a thalamotomy is basically a open procedure where they do this. They ablate or destroy some part of tissue. The advantage of this is we don't have to open your skull. We don't have to peel back your skull. You don't have any of the infections. You don't have to go through all those surrounding brain tissues to get to the thalamus because it's in the center. All those things are left alone, and we're going at it, from the outside in with ultrasound. But we're missing all of those potentially complication portions of an open procedure.
All right. And I know you guys, there's some questions that you've asked and are asking. I'm getting to them. I promise you. You got some great questions here. So we did have an earlier question. They wanted to know, does ultrasound, this focused ultrasound, does it address freezing of gait?
Yeah, that's more on the dyskinesia side of the family of things. And one of the challenges for this, and this is something I would say to anybody who's got a variety of something that I don't have tremor, but I have this. The problem with Parkinson's disease particularly is that you can have a full spectrum of movement disorder problems that it really takes someone with more brains than me to figure out exactly, can we help you and what is the best target to hit for you? And so that's why when Bobby says if you can get to a movement disorder specialist to see that, I think it's really wise to help identify what's the best target for you and then go forward from there.
And then there's one thing here, because I saw that question from Rick. I've had some issues in the past with freezing of gait, Rick. And one of the things that I found with the procedure I had, again, it targets first and foremost the tremors, which for me was the most struggling part that I had as far as symptoms go, because of not only the movement and the activity, trying to hold a cup of water, trying to feed myself, whatever it may be. There's obviously the cognitive challenges of being seen as, I always viewed myself as I was broken. I was embarrassed. I stopped coaching my sons for about an 8-year window because I couldn't stand on the sidelines, and I was constantly worried about, what are people thinking about my tremors. I used to get pulled over at TSA, and the TSA would ask me if I was nervous, was I bringing something in? Because also with Parkinson's, you can have periods of extreme sweating. So you're meeting with a TSA agent and you're sweating and you're shaking, and you have to explain that, yeah, it's Parkinson's. But where I'm going with this is by remediating and improving the tremors, it helped me really focus on that gait, the slowness of speed, because it's one less symptom and the major symptom that's behind me. Now I can focus on those mental cues where I can say, okay, heel toe, get into a rhythmic sound where again I can cognitively and mentally overcome some of that slowness of gait. I did see some improvement, but not fully improved on that slowness of gait. But that's a great question, and again something that we often have to deal with in the Parkinson's world.
Listen, thank you for that input, Bobby. I appreciate from hearing both perspectives. So we also had a question because you mentioned this can be utilized for essential tremor as well as Parkinson's tremor. So does it cover both at the same time if somebody has both types?
Well, if someone has essential tremor on the right hand and Parkinson's disease affecting the right hand, then since the target is the VIM nucleus of the brain, then that's going to treat them both. And now sometimes people say, can people have both of these things? And remember the Parkinson's disease particularly and essential tremor too is kind of a clinical diagnosis. So it's not like they have a test that they draw and it comes back yes or no. And so it's helpful to know that if the disease is not typically very well identified, it could be this or it could be that. But if the target is the same spot, the target is the key thing that we're going after. And if that's what we want, let's go do it.
Yeah, thank you for explaining that. And I guess the question that just came in is appropriate in terms of timing as far as this being utilized for other forms of tremors, such as one related to having a stroke.
Yeah, it's real important to remember that the cause of the problem is what we're trying to go after and fix. And people have strokes and other brain issues that can cause some of these types of things, and you have to really really understand what's the cause of my problem, and am I going to help with that? Because when we really haven't seen the use of focused ultrasound for somebody who had a stroke, and then they have some movement disorders that come in their body as relative to their stroke, be used to make that better. And one of the things it could be that this is still early in this technology's utilization. So I'm not saying they may find that out to be accurate later or something else, but for right now, there haven't been any studies that say we're looking for people who have right hand impact from a stroke, and then we're going to try and treat them with essential tremor. Those studies just haven't been done.
Gotcha. Thank you for addressing that. And we did have a question about whether this is available and safe for those who might be dealing with clotting disorders.
Typically, the use of focused ultrasound, one of the benefits of it is you don't have a lot of the anesthesia-related symptoms that would make you hesitant if you're 85 years old to go in and have some procedure, because it really is pretty benign to your the rest of your body, your blood pressure, your heart rate, all those things can just go on functioning as they are. Now, the clotting disorders is a pretty broad spectrum. So one of the things that I think you have to say is you go in and talk to your physician about what specific is your clotting disorder. But I think I would not let that give me a reason to say I'm not going to go talk to my doctor about this, because I think for most of those disorders, I think that they'll look at this and they may decide they're going to adjust your medication or something, but I don't think it's you can't have it.
Awesome. And I know we're running out of time, so I will ask just a couple of more questions. So one of them was, and I think Bobby mentioned this, but I want some clarification. Can you have a focus ultrasound and then later DBS?
You can have, if you're going to have focus ultrasound first and then you want to go on and have DBS, that's fine, assuming you don't have any other reasons like metallic implants in your brain or something like that. And you can have it the other way too. If you want to have DBS and for whatever reason you decide you want to go on to have focus ultrasound, you can do that, but you really want to talk to your neurosurgeon first and make sure they understand why you want to make the switch, because they're going to have to do the surgery to remove the electrodes, to remove the battery pack, etc., to get all that stuff out of there, because you have to do this in the MRI.
We have a patient that we're working with that's actually having focus ultrasound done next Thursday at Penn, who with DBS was prone to brain infections and had a couple of infections, and therefore they removed the device, and she's now going the focus ultrasound route. So you can go both ways. To your point, Dr. Meakem, making sure you're 100% aligned with your medicals team to make sure that it's the right decision for you certainly needs to happen, and happen in great depth.
Lastly, I know you talked about how you're still working on some Medicare coverage in different areas. And then you mentioned the out-of-pocket. Is there not commercial insurance coverage for this? I know sometimes when we get new medication options out there, sometimes the commercial insurance adopts it first before Medicare gets on the bus. So how's that work with focus ultrasound?
I'll speak that from the foundation standpoint. We really look at Medicare coverage because it's kind of a lot of these patients are in the Medicare age range, and so even though it's a national organization, we have these contractors that cover some areas and not others. So it's not like we say, yes, Medicare covers everything, or no, it doesn't. A lot of these contractors, some will approve it and some wait. And so it's that process. That's why for the tremor dominant Parkinson's disease, we have 38 states that are covered for Medicare, but the other states are not. For the individual insurance companies, there's just so many companies and plans and stuff that we really don't keep track of all that. We say you're just going to have to talk to your plan and find out, because there's just too many for our organization to keep track of. I don't know if Bobby has information more on that.
And as a whole, and listen, Dr. Meakem, if you have essential tremors, diagnosed with essential tremors, the likelihood of having insurance coverage is significantly higher for non-Medicare age than those with Parkinson's. There's a little bit more challenges with United Healthcare has been really a challenge, I know, for a lot of people in the Midwest, but it just doesn't quite have the depth and breadth that it does currently for essential tremors. Therefore, the need for the assistance from the Be Still Foundation for financial support.
Well, thank you so very much to both you, Dr. Meakem and Bobby. I appreciate both of you giving your time and your perspectives. Bobby, we did appreciate you sharing your information about your Be Still Foundation. We have dropped that link in the chat if you guys want to save your chat, and you can go back to that later if that's something you or someone you know might be interested in and looking into further. And also the Focused Ultrasound Foundation as well. We put their information in the chat. So if you want to follow them to get the most updated news, then please do so. I want to thank both of you so much for your time today. And I will tell you, there's a little tradition here at PMD Alliance that we do to thank our speakers. And so I am going to invite everybody to give you that wave of gratitude to both Dr. Meakem, to Bobby Krause for sharing your time and your experiences today.
Thank you very much.
Thank you so much.
Thank you both. And thanks everyone. Hope you have a great rest of your day.